Hello and welcome to the sixth and final episode in the series of podcasts on peripheral vascular disease. In this podcast, I'm going to discuss atherosclerotic disease which affects the carotid arteries, otherwise known as carotid stenosis. The risk factors for carotid stenosis are the same as the risk factors for atherosclerotic disease anywhere in the body, and just to recap, these are smoking, hypertension, hypercholesterolemia, diabetes, and a family history of atherosclerotic arterial disease. Patients with carotid stenosis are frequently asymptomatic. However, if the blood supply to the brain has been disrupted, causing transient ischemia or a cerebral infarction, patients may present with symptoms such as episodes of weakness, dysphagia, dysarthria, and visual disturbances. In addition, when taking the history, it is also important to ask the patient about amaurosis fugax, which is characterized by a transient loss of vision in one eye caused by embolism within one of the retinal arteries. The underlying pathophysiology of cerebral ischemia or infarction as a result of carotid stenosis is similar to that of atherosclerotic disease, which affects the heart or the peripheral arteries of the lower limbs. The atherosclerosis within the carotid arteries can in itself occlude blood flow to the brain, thus causing ischemia, and in addition, an atherosclerotic plaque within the artery may rupture, leading to thrombosis and embolism to a more distal vessel within the cerebral circulation. On examination, it may be possible to hear a bruit over the carotid arteries. However, this sign is neither sensitive nor specific, as a bruit may not be heard even in critical carotid stenosis. Furthermore, any bruit heard in the carotids may be related to the radiating murmur from aortic stenosis within the heart. It is also important to perform a full neurological examination in order to assess for any focal neurological deficit which may be consistent with a previous cerebral infarction. In addition, it is vital to perform a cardiovascular examination in order to look for other potential sources of emboli into the cerebral circulation, for example as a result of atrial fibrillation, as well as to rule out the presence of an ejection systolic murmur radiating to the carotids consistent with aortic stenosis, which may be confused with a carotid bruit as a result of carotid stenosis. There are several investigations which should be performed in any patient who has experienced cerebral ischemia or following cerebral infarction. These include an ECG in order to look for atrial fibrillation or signs of ischemic heart disease. In addition, blood should be taken for a full blood count to look for anemia, which may precipitate an ischemic event, as well as to check renal function and fasting glucose and lipids to look for diabetes and hypercholesterolemia, which may increase the risk of atherosclerotic disease. Imaging investigations such as CT or MRI scanning can be used to rule out cerebral hemorrhage and to look for previous foci of cerebral infarction. In addition, CT or MR angiography may be performed in order to look for sites of narrowing within the carotid arteries or the cerebral circulation, which may be consistent with atherosclerotic disease. Finally, a duplex scan of the carotid arteries may be performed in order to assess the level of stenosis. In terms of management, as for all atherosclerotic disease, risk factor reduction may play a profound beneficial role in improving prognosis. This includes smoking cessation, blood pressure control using antihypertensives, statins to reduce cholesterol and for secondary prevention following a cerebral infarct, and aspirin in order to reduce the risk of future thromboembolism. In the presence of severe symptomatic carotid stenosis, surgery in the form of carotid endarterectomy can play an important role. Data from the European Carotid Surgery Trial and the North American Symptomatic Carotid Endarterectomy Trial suggest that in patients with symptomatic carotid stenosis, that is to say, patients who have experienced symptoms of cerebral ischemia or a history of a previous cerebral infarction, and who have severe carotid stenosis in excess of 70%, as demonstrated on a duplex scan, may benefit from a reduced incidence of stroke following carotid endarterectomy. The NNT, or number needed to treat, is 6. This means that for every 6 carotid endarterectomies performed in patients who fit the criteria, 1 stroke will be prevented. The data also suggests that carotid endarterectomy may be beneficial in patients who are not symptomatic but have severe stenosis over 70%. However, the evidence is not as strong as for symptomatic patients, and so carotid endarterectomy is usually only undertaken in patients who are symptomatic. Carotid endarterectomy is a surgical procedure in which the carotid artery is clamped and incised, and subsequently any atherosclerotic plaque and the artery intima is removed. This reduces the risk of future thromboembolism and thus reduces the risk of stroke as a result of carotid stenosis. The procedure may be performed under local anesthetic, which has the benefit of allowing the surgeon to assess the neurological status of the patient in order to ensure that adequate cerebral perfusion is maintained throughout the procedure. An artificial bypass shunt may be used during the procedure in order to maintain perfusion to the distal vessels. A shunt should always be used if the procedure is being carried out under general anesthetic, in addition to monitoring cerebral blood flow using a transcranial Doppler probe. This is because, under general anesthetic, it is not possible to assess the patient's neurological status in order to check for adequate cerebral perfusion during the procedure. As for all surgical procedures, complications of carotid endarterectomy include local wound infection and sepsis, as well as bleeding. Specific complications include intraoperative stroke, which may occur in up to 2% of patients. Immediate complications following surgery may include the formation of a local hematoma, which may compress on the trachea. If this happens, the patient should be taken back to theatre urgently in order to have the hematoma decompressed in order to prevent asphyxiation. Other complications include damage to the surrounding nerves, particularly the hypoglossal nerve, which supplies the muscles of the tongue. So to summarize, in this podcast I have discussed atherosclerotic disease affecting the carotid arteries and how this may increase the risk of cerebral ischemia and cerebral infarction. I have discussed the importance of risk factor reduction in improving the prognosis of atherosclerotic disease in general, as well as specific surgical intervention in the form of carotid endarterectomy in symptomatic patients with a carotid stenosis greater than 70%. The specific complications of such surgery include bleeding, which may lead to a localized hematoma where there is risk of tracheal compression, in addition to nerve damage affecting the hypoglossal nerve. So this concludes this podcast on carotid stenosis and the series on peripheral vascular disease. I hope you've enjoyed this series, and if you have any questions or comments relating to any of the podcasts in the series, please don't hesitate to contact me. Please do also take a look at the website www.podmedics.co.uk, where you can find my contact details as well as other series of podcasts in clinical medicine. Thank you for listening.